Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And I wanted to welcome you all today to Journals Club. This is an opportunity again to discuss our lead article, and we're really very grateful to have these two really outstanding discussants. I also want to thank ESGO and IGCS for their support in our journal. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording, so we ask that everyone please keep your microphones muted so everyone can hear the presentation. If you're having any difficulties or questions, please send a message in the chat and our technical support will assist. We will definitely have time for questions and answers, and we absolutely encourage all of you to participate, to submit your questions via the chat function through the today's session. So this month's lead article is the article titled Oncologic Outcomes Based on Lymphovascular Space Invasion in Node-Negative FIGO 2009 Stage 1 Endometrial Adenocarcinoma, a multi-center retrospective cohort study by Chris Dagher and Nadeem R Abu-Rustum and their colleagues. And I'm really very pleased to welcome them to join us today for this podcast. Nadeem, Chris, thank you so much for being with us today. And of course, obviously, sharing your insights in this really important article. I'm really looking forward to hearing the presentation and your discussion. So with that, I'll pass it on to you and we can start the presentation.
Perfect. Thank you so much, Dr. Ramirez, for the opportunity that you gave us. All right, so today we're going to be presenting the study that we done with our partners in Oslo, Norwegian Medicine Hospital. And then we already know that numerous studies have highlighted the prognostic importance of LVSI as a really important prognostic markers in endometrial cancer, particularly endometrial cancer, noting its correlation with high-risk factors in the uterus, such as deep myometrial invasion and high-grade tumor histologies, as well as the occurrence of nodal metastasis. Recently, there has been an increased interest in classifying the extent of LVSI. This was driven by the association with its disease outcome and disease spread. But the available literature that we have so far has been very heterogeneous, whether it be from using different cutoffs to being performed on different populations, on-stage patients, even looking at different oncological outcomes, like looking at pelvic lymph node recurrence, looking at progression-free overall survival. So really the data is heterogeneous. Fast forward in 2021, the WHO proposed the use of a cutoff for defining the extent of LVSI by using 5 or more LVSI or like vessel involvement in at least one pathological slide to define substantial lymphovascular space invasion. And in 2023, FIGO included the extent of LVSI in the staging of endometrial cancer, using the WHO definition. But we don't really know, and the data that we already have available on that matter doesn't use that cutoff, and we don't really know what that cutoff could mean, or does it translate really in terms of oncological outcomes. So the primary goal of our study was to compare the progression-free survival across these LVSI groups using the WHO classification, but also wanted to look at the overall survival for the total cohort, in addition to comparing both progression-free and overall survival specifically in the subgroup of myoinvasive grade 1 and 2 tumors. Because we see later on in the FIGO classification that this particular subgroup bodes importance in terms of staging, with upstaging of patients who have substantial LVSI and considering patients who have focal LVSI and no LVSI as having the same oncological outcome. And we wanted to see what our data tells us. So this was an international retrospective multi-institutional cohort study involving patients from 2 centers, Memorial Sloan Kettering in New York and Oslo, and Norwegian Radium Hospital or Oslo University Hospital in Norway. We included patients with endometrial and endometrial cancer who underwent surgical staging and were found to have FIGO 1009 stages 1A and 1B that received care at our institutions between the years 2012 and 2019, In terms of staging, it included hysterectomy with bilateral salpingo-oophorectomy and pathological evaluation of at least the pelvic lymph nodes bilaterally. Later on, our amazing histopathologist, they reviewed and categorized the patients based on the extent of lymphovascular space invasion, and they divided them into three groups: no LVSI, focal LVSI, and substantial LVSI after central pathology re-review. And we adopted the WHO cutoff of 5 LVSI to distinguish substantial from focal. All right. In terms of our result, going from left to right, let me just move the slide here. There's some lag. Of 1,555 patients that we identified between both centers, we found that 8% of our patients had focal LVSI, 4% substantial LVSI, and the rest, 88%, had no LVSI. And this was after central pathology review for patients who had suspicious or positive LVSI. And then moving on to the graphs on the right, we also noted that the proportions of grade 2 and 3 histologies increased as the extent of LVSI increased. And the same was found also for the depth of myoinvasion, with higher proportions of deeper myoinvasion in tumors with substantial LVSI. The median follow-up duration of our study was 61 months. And during that period of time, we found that the presence of any level of LVSI significantly decreased the progression-free survival. Specifically, we found that the 5-year progression-free survival for patients for tumors who had no LVSI was 91%, compared to 71% for those with focal LVSI and 69% for those with substantial LVSI. Now, moving on to the graph on the right, and we found that this was even valid in patients who had tumors who are myoinvasive and who had only grade 1 and 2. And in the multivariate analysis, we found that there was no significant difference in the progression-free survival, even when we directly compared focal LVSI to substantial LVSI after adjusting for all of the other covariates with an adjusted hazard ratio of 1.18 and a confidence interval including 1. And this is again when comparing focal to substantial. So in conclusion, our results do not support that focal and substantial lymphovascular invasion are prognostically distinct, even when looking at myoinvasive grade 1 and 2 endometrioid cancer. But more importantly, we found that focal lymphovascular space invasion with 4 or less vessels involved on at least one pathology slide and low lymphovascular space invasion do not share the same prognostic outcome. I'd like to thank Memorial Sloan Kettering for giving me the opportunity to work on this project. I'd like to thank Dr. Abu-Rustum and Gerda from Oslo and Pernell, and all of our pathologists, Ben Davidson, Dr. Allenson, and Rafida. You have been all amazing. And I would like also to acknowledge the Bob's Foundation, without whom this project would have been possible.
Great, fantastic. Thank you so much, Chris, for that presentation. And really excited to see that we have almost 40 participants in the Journal Club. So absolutely encourage questions from all. But I'll start with, fairly simple question. And, certainly for you, Chris, or Nadeem, or Pernil, obviously for many years, we were just depending on the yes versus no LVSI. So why this pursuit of the focal versus substantial versus the no LVSI? Why don't we go back just to the old system?
Maybe Chris, I can start and then you can follow if it's okay.
Yeah.
Thank you for the presentation. So that's a very important question, Pedro. And I think the main driver for this is some of our expert colleagues in pathology, particularly led by colleagues in Europe, feel that in order to accurately feel comfortable with the diagnosis of lymphovascular space invasion, you have to have a certain amount of those vessels. They are concerned that pathologists may overcall LVSI if it's not florid. So part of the push now is that we will only be comfortable saying somebody has lymphovascular space invasion if we see a certain number. And that cutoff is still being debated. Should it be 3? Should it be 4? Should it be 5? WHO picked up 5. So I think representing their viewpoint, they're saying that we're not going to count 1 or 2 or maybe 3 vessels because that could be artifact, that could be an error, could be overcall. We're only going to call it if you're seeing 5 or more. Our argument is that with expert GYN pathologists, if you see 1 or 2, it really matters. If you see 3, it really matters. So that's kind of the two sides of that.
And Nadeem, as a follow-up to that, what is your sense of the reproducibility among pathologists to really differentiate between focal, substantial LVSI?
So that's a very hot topic for pathology, and I have to give credit to the 2023 FIGO system because it really ignited a whole field of research, like our collaboration with Oslo, to really look at LVSI in a lot more detail. So for us as clinicians, we're excited about it, and I think you can see that in the pathology community too. It's really generated a lot of interest to standardize the definitions, make it easier so pathologists can agree of what is LVI, what's not LVSI. A lot of expert leaders in Europe in pathology have recently also published on this. Jelling Bossi has been leading a lot of this. So I think it has really generated a lot of excitement. There is absolutely still no consensus. And to be clear, the WHO definition of 5 or more was not based on data in surgically staged patients. It was more of a consensus between a community of expert GYN pathologists. So I think for us, we were really excited to show data in surgically staged endometrioid with negative nodes, negative washing, to really see, does this really matter? And our data does not support it. But again, it's still a very interesting area of development.
Fantastic. So we're going to start with some of the questions from our fellows. And first, we will go to Roberta Masobrio.
Yes, thank you. My question concerns again the definition of focal and substantial lymphovascular space invasion. The pooled analysis of the PORTEC 1 and 2 trials, which identified an association between substantial lymphovascular space invasion and oncologic outcomes, defined substantial LVSI as diffuse or multifocal invasion, without quantifying the number of vessels involved. On the other hand, as we know, the WHO criteria defines substantial LVSI as the involvement of 5 or more vessels on at least one pathology slide. Do you think that redefining focal and substantial LVSI could improve their prognostic value?
All right, Dr. Abu-Rustum, if you don't mind, I can start, and then please let me know if you need to add on anything. So thank you first, Roberta, for bringing up this important question and this nuanced question. So if I understand correctly, you're asking whether changing the LVSI cutoff, say using 4 vessels instead of 5, would significantly alter the results of our study or any study that is similar to ours. In short, this seems unlikely. And if it did affect the outcomes, I'd be very curious to know whether the change was driven by the extent of LVSI or if it mostly by the loss of other high-risk factors that substantial LVSI involvement is usually associated with. Like, for example, if we lower that cutoff to 2 vessels or 3 vessels involved, are we only selecting the grade 1 and no myoinvasion subgroup? And that would be a really important question. At that point, finding no difference would be mostly driven by those, as if we are comparing no invasion versus more than 50% invasion, and not more like a question of whether LVSI is driving this difference.
Thank you.
Excellent. Now we'll turn it over to Susana Del Frati.
Thank you very much for your amazing presentation. I would like to ask you, in the initial database from supplemental table 1, there were 15 suspicious lymphovascular space invasion. 6 out 15 were no LVSI. Does this mean that LVSI can be hard to interpret for the pathologist? Are these microcystic, elongated, and fragmentic MELF-like patterns? Thank you.
Yeah, also another amazing question. I would have to say that and I would like to echo back to what Dr. Abu-Rustum has already alluded to, that really identifying LVSI requires a lot of expertise and a lot of consensus and a lot of practice from our expert pathologists. So yes, there could be some MELF pattern that could have been seen that was considered as suspicious. And I have to really remind the audience is that the cohort that we have included is patients that go back to 2009, right? Sorry, 2011, 2012, 2019. So basically there's a wide range of years during which the understanding of LVSI has evolved. And this is why we needed to go and look back at those patients who had tumors with suspicious LVSI and really evaluate them by the same operator to try to identify whether those suspicious LVSI were just tumor displacement during treatment or were like MELF pattern. Unfortunately, we did not really document what was the outcome for those patients who we deemed negative for LVSI, but I'd have to say like 6 out of 15 wasn't gonna change much of our management, and but yeah, that's a really important question.
Thank you.
Thank you, Chris. And I'm sure you're so glad that Susana went into the appendix and the tables in the appendix. So she really is very thorough in her evaluation.
Which I really appreciate this because there's a lot of work that usually ends up being in the supplementary, and then as an author, you'd always be really heartbroken whenever you put yourself in the supplementary.
Very well. And then also, I mean, Chris, if you're gonna for some in the audience, can you speak a little bit about like what MELF pattern is and how that might influence these definitions?
So microcystic, elongated, and fragmented pattern of invasion is one of the major mimickers of lymphovascular space invasion. And usually how our pathologists try to address this, and I have to say my background is purely clinical, so I might not be the best person to give a lecture about MELF pattern of invasion, but I'm really passionate about pathology. And they would try, whenever they have a suspicious focus, they would try to use staining methods to try to identify and differentiate it from MELF from LVSI. Like I know that back in MSK, they used CD30. They used also a lot of different immunostaining technique to differentiate LVSI from MELF. There has been some reports linking MELF pattern of invasion with the presence of LVSI. So whether finding MELF is just a surrogate marker of us not being able to identify that focus of LVSI is a really important question, I think a hot topic. And I'm eager to see if there is any future work that is going to be able to identify that link and just hammer down on that point.
Great. Thank you for that, Chris. And again, I want to encourage those who are in attendance to submit their questions. This is your opportunity to speak or communicate directly with the authors of the manuscript. You know, certainly, oftentimes it's not just LVSI. Oftentimes it is additional risk factors, and that brings us to the next question by Elena Rodriguez Gonzalez from Spain.
Hello. Thank you, and congratulations for the study and the presentation. My question is if you perform subgroup analysis of those with isolated tumor cells or positive peritoneal cytology.
Thank you so much, Elena. So as most of you know, I mean, in our paper and our study, we did exclude patients with ITC and those with peritoneal cytology, positive peritoneal cytology. And the reason for it is that we wanted to have the purest cohort so that our analysis basically gives us more like a final answer without some ambiguity about the results. Yeah, so we did not really look into ITC and we did not really look into positive peritoneal cytology.
Very well. So now we turn to Raikan. She has the next question for the authors.
Thank you for your presentation. And my question is, what would you say was the reason that led to different results from your results and pooled PORTEC 1 and 2 studies? Thank you.
Thank you so much, Raikan. I think the major difference is that in the analysis of pooled PORTEC 1, PORTEC 2 trials, the patients were not surgically staged. And and knowing that LVSI is highly correlated with lymph node spread, the fact that we have selected a large cohort of patients with negative nodes based on lymph node evaluation makes a huge difference between our results. So, and this translates directly to how the FIGO 2023 staging is proposing to use LVS, extent of LVSI. So nowadays, when sentinel lymph node mapping is becoming more and more available to everybody, and then surgical staging and lymph node evaluation is becoming like a cornerstone of any staging, I believe the results that we show could be more reflective of the role of LVSI and the extent of LVSI in that particular subgroup of patients. And Dr. Abu-Rustum, feel free to let me know if
you said it very well, Chris, and it's a great question. But just remember that whenever you have any degree of myoinvasion with lymphovascular invasion, these two together, your chance of metastasis to pelvic lymph nodes become 10% plus. So you can imagine in a cohort of patients that were not surgically staged, you never removed lymph nodes, or you only removed lymph nodes randomly on a few of them. There's going to be a substantial group of patients that have positive nodes. So basically stage 3 disease is being lumped with stage 1 disease. Our cohort, we are very confident in those 1,555 that these were node negative surgical stage 1. So this is a clean group that we controlled histology, we controlled lymph node status. When you are using a database without surgical staging, you're running some degree of error of dealing with patients with higher stage, which will have a different recurrence pattern than those that are purely surgically staged. So that's our main, I think, strength in doing this, to try to keep the cohort as clean as possible, surgically staged, bilateral negative nodes, etc.
And Nadeem, as a follow-up to that, if you do see a patient that comes to you that had a hysterectomy done by a general gynecologist and now coincidentally comes in with a tumor that has myoinvasion and they have substantial LVSI, of course, obviously, they didn't have any lymph node evaluation. Is this the type of patient that you would be more willing to say, yes, you should go back to the OR for staging versus, no, don't worry about it, we'll just go by the hysterectomy specimen and whatever molecular profiling we have?
That's a great question. I think this becomes very relevant if somebody has endometrioid histology with myoinvasion and LVSI, regardless of the amount of LVSI. So that patient who now has endometrioid, even low grade, that has any degree of myoinvasion and LVSI probably runs at 10% plus of having microscopically positive lymph nodes. So if the patient is suitable, restaging with a pelvic lymphadenectomy is reasonable, because if you do that and you're comfortable that the nodes are negative, you can potentially de-escalate her adjuvant therapy, and you may just give vaginal brachytherapy depending on uterine factors or observe. If you don't, you have to give her the information that you may have this percentage of nodal positivity, and then external beam radiation may be appropriate. So I think in endometrioid histology, this is very useful. However, if you have a serous or a carcinosarcoma, I'm not sure that that's relevant anymore. But this paper was about endometrioid. And again, the FIGO staging system is about endometrioid when it comes to the quantification of LVSI. It's really actually restricted to grade 1 and grade 2 endometrioid.
Very well. We have a question from the audience, one of our fellows, former fellows, Ana Luzarraga. Ana, if you want to proceed and ask your own question.
Yes, hello, congratulations on this amazing study. I enjoyed it a lot. So my question is, according to the worst oncologic outcomes of the group with focal LVSI, do you consider that this group of patients should undergo the same adjuvant treatment that those with substantial with your results? Thank you.
So we have to be very careful here of taking the results of this research and recommending adjuvant therapy. There's a difference between us saying you have a 3-fold increased risk of recurrence because you have LVSI and you're surgically staged, and then saying you should get external beam radiation or chemo. That has not been proven yet. In a good scientific process, we should be able to prove that there is benefit in adding additional treatment. So we're very cautious about making a statement about adding more radiation or chemotherapy to this cohort of patients. So all we can say right now is that even in surgically staged patient, any degree of LVSI is important because it can increase your risk of recurrence, but we cannot make a statement that because you have LVSI, you should get pelvic radiation or you should get carboplatin paclitaxel. That needs to be proven. We have to be very, very careful about just jumping to making recommendations for adjuvant therapy without proving benefit to the patient.
Excellent. Next, we have a question from Tere Pan. Tere, do you want to go ahead and proceed and ask your question?
Yes, thank you. Thank you for the presentation and interesting data. My question is a little bit similar of that of my colleague, and these data are pretty impressive and pretty like decisive. And what do we need next? What would you think the next step should be? And if we're not there to like adjust treatment for these patients, but is there a sense in considering to adapt follow-up for these patients?
So I think this was a good start for us. It allows us to really see this more in depth. We're continuing research in this area, and we will have more papers hopefully submitted and reviewed. Other colleagues have also published similar data from institutions in the United States and surgically independent work that validated this. It would be good to see this validated more than just our institution. I think we tried not to make it a single institutional paper, but our collaboration with Norway, Norwegian Radium Hospital University, I mean, that was really very precious for us because this was a completely different cohort, completely different expert pathology. And we really, it was just beautiful to see that these two institutions could actually unify the data. So we encouraged other peoples to use good methodology, use surgical staging, use negative bilateral nodes, have expert GYN pathology review, and see what you find in your data. We would love to see what others come up with. And again, it's an evolving field, so things change. We may learn more. I think for now, this is the data that we have, but certainly it's just a beginning for us. And it sends a good message that we probably, before we push guidelines and before we push recommendations, that we really should let the science drive these decisions, let the science and the data drive. That's the safest way for us to make these changes.
Fantastic. Thank you so much, Nadeem. And Tere, I think that calls for a collaboration between Austria and Houston Methodist then. That's how I see it. All right. So next we're going to Turkey. Mina Dagis.
Hello. Thank you for the presentation. My question is, do you foresee a future where LVSI could be replaced with another alternative method like HPV testing being replaced by for cytology for cervical cancer?
Chris, you want me, or what would you like to do with this one?
So if I understand your question correctly, Mina, is that you're comparing looking at LVSI as we look at cytology before we introduced HPV as a screening methodology, right? The premises are quite different in my opinion. I think LVSI is not a screening tool, whereby like cytology was a screening tool for cervical cancer. So I cannot really draw parallels, but I certainly believe that LVSI has a prognostic role, definitely not in staging, but basically to inform basically the prognosis for patients whenever we counsel them about the risk of recurrence in the future.
Excellent. Very well. So now back in the United States, Salt Lake City, Ali.
Hi, thank you. Congratulations on your wonderful study. This study shows evidence of supporting and revising the FIGO 2023 staging. Are there any other results that you could share with us that you would have with FIGO 2023 staging?
So
thank you so much, Ali. Yeah, go ahead, Dr. Abu-Rustum.
Well, Chris has done a lot of work, and we are working on his second manuscript now. So we do have more data, and I think others do as well. So we will certainly, again, stick with the message of being very careful with the data and what we put out. You know, it took us a long time to get this done. We've been working on it for a couple of years, so we did not rush things. We really wanted to be 100% something we can stand by. So that's kind of what we're doing right now. We're continuing to work. Again, this is not because we want to, you know, change something or we want to go against something. We're just trying to see what does the data say, so we can be informed all as a community. And again, I have to give a lot of credit for 2023 FIGO because it's generated a lot of research, a lot of good projects, which is making us all understand this disease much better. So that's something that really has been very exciting in the last couple of years.
Excellent. And we'll turn now to Jose Vilches, who's in now one of my favorite cities after having visited for a few days last month in Malaga, in Spain. Jose.
Thank you, Pedro. Thank you, Dr. Dagher and Dr. Abu-Rustum. Okay, my question is similar to some of the audience, but in your study, you mentioned that no significant progression-free survival or overall survival benefit was observed with the adjuvant treatment in the patient with lymphovascular space invasion. So, how should this affect to the decision about the adjuvant therapy for patients with not negative FIGO stage 1 endometrial cancer? Could you share with us how do you manage this patient in your institution, please? Thank you.
So this is a good follow-up question. It's very important that we not mix a strong recommendation of adjuvant therapy to the findings that we found. So again, the caution here is that because you find some increased risk of recurrence, automatically we're going to say, let's use external beam radiation, let's use chemo. That would be a mistake, and that's not supported by the data in this paper. For our institution, and again, I think Oslo may do things differently, and Pernille may still be with us or not, but you know, for our institution in endometrial cancer, stage 1, that's surgically staged, we try to be conservative with additional treatment. So as you know, the addition of radiation can improve local control, but has never been shown to make people live longer. So you have to also be careful with that. It has some potential toxicity, not only to the patient, but also cost and financial toxicity. So, you know, we look carefully at who may benefit from intravaginal brachytherapy. I think we're very conservative with external beam radiation when in patients that are surgically staged, negative node endometrioid. So those patients, if they're stage 1, we usually do not recommend external beam radiation for them. And then again, the role of chemotherapy remains to be defined, will probably be pushed more and more by molecular profiling, possibly in the group that's P53 abnormal. So we can potentially get to a point you're surgically staged, you're endometrioid, but you have myoinvasion and you have a P53 abnormal tumor. Very comfortable with that. It is possible at some point that we may reach a point of saying, yeah, chemo will make you live longer. I don't know if we're there yet in that group of patients, but I mean, that's the hope. The hope is that from all this learning, we will be able to do something that's better for our patients. So these studies are exciting. We're learning more. But if you see it from the patient standpoint, well, what can I do to make things better for the patient? This paper does not tell us, you know, what to do. All it tells us is that LVSI is important. Quantification may not be as important as previously suggested, and we need to continue research to see what can we do to potentially decrease the risk of recurrence and death from this disease.
Great. Pernille, do you want to add anything as it pertains to experience in the Norwegian?
Well, so in Norway, we do not administer radiation anymore. We stopped in mid-2000 actually. So we do not give brachytherapy, we do not give external beam therapy. We treat them only with chemotherapy or now recently with immunotherapy, according to the Ruby trial. So these patients included in this study would not have been given, the grade 1 and grade 2 are not giving any adjuvant treatment at all.
So Pernille, is that to say that the Norwegian Radium Hospital is now just called Norwegian Hospital?
Yeah, we should consider change our name, but that would, I guess, change our brand. So yeah, we stick with the radium, but we're not as radiating anymore, I guess.
Or the new name, the Norwegian Chemotherapy and Immunotherapy Hospital.
Yeah, sure.
Listen, I have to give them a lot of credit because they're purists and they go by the data. And again, I think if you really want to go by the data, their practice actually is supported by data. So we like I said, we give radiation, particularly interventional brachytherapy, knowing that it's not going to improve overall survival, but may improve local control. So really, what they do in Oslo is supported by data.
Great. And Nadeem, as a follow-up, you mentioned about obviously molecular profiling and subtyping of the patients with substantial LVSI, and perhaps we don't have enough numbers to determine, but is there any particular molecular subtype that is most characteristics of the patients that have substantial LVSI?
Yeah, that's a great question. We did not look, and we can certainly look at, I mean, it's only 4% of the entire cohort that has substantial LVSI. And again, if you look at the, the definition of 5 or more, you can see a whole spread of people who had 5, 6, 7, 8. The highest we've seen was 22 LVSI per slide. So it's really all over. It's not like, you have 1 or 2 and then it jumps to 7 or 8. Those patients were spread up to 22 vessels per slide. It would be interesting. I think it's a very good point, Pedro, and we can certainly look at, in general, this group of patients is most likely going to fall into that no specific molecular profile. But again, I think this is a good one for us, Chris, to try to tackle, to answer Dr. Ramirez's question.
Yeah, and I think it'll be a point for discussion when we have the 3M conference that's coming up at the Mayo Clinic, the 3 institutions, Memorial, the Mayo Clinic, and the Methodist now, meeting in January on the topic of endometrial cancer. So looking forward to those discussions as well. Well, we're coming to the conclusion of the Journal Club. I want to thank, of course, obviously, Chris, Nadeem, Pernille also for attending the Journal Club, and of course, obviously, to all of the fellows that participated in the Journal Club, the fellows who brought their questions, and then those of you in the audience who submitted your questions as well. Nadeem, Chris, thank you so much, and again, congratulations to you and the rest of the group, and the cooperation that you had with collaboration that you had with the Norwegian Hospital.
Thank you so
really
much,
great.
Pedro. Thanks for giving us the opportunity to present. Thanks for looking at this paper and seeing it favorably. We really appreciate this, and wonderful collaboration with our colleagues Pernille and Anna Gerda Eriksson, and Chris. You're doing a great job, and thanks everybody for giving us the opportunity.
So I want to remind everybody that recordings from today's session will be available in the IJGC, IGCS, and ESGO websites. Next month's Journal Club will be discussing the lead article, Racial and Sociodemographic Disparities in the Use of Targeted Therapies in Advanced Ovarian Cancer. I want to thank you all once again, and have a great rest of your day and rest of your week. Thank you.
Bye-bye.
Thank you. Bye-bye.